Welcome. I'm glad to be here and I hope my accent improves over this coming 10 minutes. So I'm going to tell you a bit about the model, and I have to warn you, I'm really in favor of the model. I implemented it like 12 years ago in the Netherlands, and it's flying there. Mostly antenatal, but now postnatal it starts more and more and more because those parents that did it antenatally now want it after birth. So I'm really happy about it, and I'm also involved in projects around the world, and it's the same experience I'm getting back from care providers, from parents that really like it. So that's why I'm going to sell it to you, sort of. As Linda said, it has these three components. It has health assessment, it has interactive learning, so you don't want to do like what I do now, teach didactic shit. You don't want that. You want people to talk and, talk with each other and come up with solutions. And there's a lot of stuff going in there to create peer support. And how nice is it as healthcare providers that you make sure when these women or parents walk out of the room, they know each other, and they know each other for good, and they know how to help each other, and they, you are going to be gone as a healthcare provider one day or the other, but they still have each other. That's what you want to accomplish, right? So you, instead of just one-to-one visits, you can have them for people that really need it. But in general, you do your visits with a group, and it's like 120 minutes. You do your health assessment, and then you talk about the things that really matter to these parents, and in this facilitative way. And you make sure it's a stable group because you want people to know each other at the end of the series of meetings. So what's in these, like the old-fashioned model, the centering parenting model, what's in there already? It's always geared toward health, safety, and development of the child, but also of the mother mostly and the parent. It's not only about the child. That is a difference maybe with youth health care as it is now. Well, for sure it was in the Netherlands. So these are the topics that are in it now, already incorporated in the model. These are all the things that are being talked about. And as you can see, there's a lot also about, for instance, like there is domestic violence, like there is also a mom getting physically better again. And it's also about all the child stuff, the crying, the sleeping problems, nutrition, but it can be improved. And that's what you will hear later, that the colleagues here in Leeds are going to improve this model with. And for instance, you also cater it to your local population. For like the yellow square, that was with our Eritrean women. We did a lot about how the system worked, because they didn't have a clue where to go and who to call. So you incorporate all these elements depending on your population. With our Nigerian women in the refugee centers, we talked a lot about, not getting pregnant again, because they thought if you eat a lot of salt, that is a good contraceptive. And then we started to talk about how the female body works. And they were really interested, more than the children actually. They really wanted not to have more children. So like a couple of sessions were about how does the female body works, and they came and they really wanted to learn about that. So you might shift your topics to really keep your audience enthusiastic. I'm enthusiastic, I'm happy with it, but fortunately there's also science to back it up. I really like that. Of course, there's a lot of science about antenatal group care model. That's good, amazing, fine. I talked about it another time, but there's also now more and more science coming on the postpartum group care model. It's still limited, but it's growing. So with this project, we'll add to that. So in a couple of years, I can stand here and talk about all the scientific backing up science for the postnatal model. There was one systematic review I will show, you can all read it. 19 studies, of which they were all from the USA or Canada. They were all with a medical health assessment component. So that was the model that they researched. And there were 8 in high-risk populations of the 19. And what this systematic review showed, that it also, the outcomes in the parenting model seem to look better than in the individual care. It was always compared to individual care. Well, the first one is easy, more content. Yeah, it's a lot easier if you sit 19 minutes with someone that you can talk about stuff than if you have your 10-minute, 15-minute, 20-minute one-to-one encounter, which you will say all the same things all over again. This was a great one. It showed to be as effective as individual care. Now, of course, we want to be more effective, but I know a lot of people think, especially in high-risk populations, that it is not as effective for these high-risk populations, but the review showed different. There were only 1 or 2 studies that showed reduced utilization of emergency care or illnesses in between and improved weight-related outcomes. I mean, it is still thin for the postpartum period, but it's getting there. And especially when they looked at these 8 studies with a high-risk population, you saw the review concluded why it would also work there and provide better outcomes in these populations. And I think for leads that's a very important thing to know, although I'm convinced you should offer it to everyone and not just a selected group of parents. It is preventive health care in the beginning. It's changing your system of care. It's like, come on, let's not just look at medical stuff. Integrate social and medical domain, and this is what you provide to everyone, so you get a lot of problems sorted or solved in the beginning, and then you probably need to have extra care for those that really, really are high risk, but you can start at an earlier stage. All right. After 2021, after the review, there were 2 other studies that came out, and they came up with these outcomes: increased attendance rates of parents, increased immunization rates, more parent satisfaction. You see that in every study, so that's an easy one. They were more into completion of psychosocial screening. It's easier to meet parents' needs because you sit and talk with them for 2 hours every time, and you sit and listen and you observe and you get to know them actually, and they get to know you, which is also very nice. That way it may also be easier to provide culturally effective care. We see that in our refugee centers in the Netherlands. The youth health visitors, I have to get this right, they do it there, and they just sort of understand who they're with, because they talk about stuff that's important to them. They don't do their program, they sit and talk and listen, and women go out there and they continue to talk. Other factors associated with success from the review: start early. Don't wait until everyone starts to go back to work, because they won't join your groups anymore. So start as early as you can. We try in the Netherlands now to have the antenatal groups never to stop. Just keep on going. You'll have a bunch of pregnant women, you have a bunch of moms who already got the baby, and that would be the best, I guess, because then they can teach each other. Let it run for some time. You want community building. Don't stop after 3 sessions. Let it go on. Facilitate that it can continue. Not small groups, because then the big mouth will have the word, and you don't want that. You want different opinions, you want them to chat shit, and you want them to make friends, and there's always one person that can be your friend in a group of 10, but in a group of 3 it might be harder, right? If you can, do antenatal and postnatal in the same area, because it's a lot easier to recruit women when they did the antenatal ones. But buy-in at all levels, and Octavia can confirm that, is very important. So if you want anything on how to do it in practice in the UK, talk to her, stand up. Octavia, she did it in the UK. So because maybe you don't believe a Dutch person from the Netherlands. I understand that perfectly well. But she's from the UK. they done it here, so it works here as well, right? So talk to her later. Having all said that, yes, you'll have some hurdles. It's a system change. It is, you know, you have to invest, but it's a lot of fun too. So just go for it. Just do it. Conclusion, it's efficient. It's a patient-centered approach. You wouldn't believe it with a group of women, but it is, because you have a lot more time to really go into the stuff that women and parents like. It influences the parenting some health outcomes. We don't have a lot of scientific background on that yet, but still, it's promising. Promising for underserved populations, definitely doable, and a lot of fun. And it takes time, already said that. And you have to overcome barriers. Oh yeah, but like, life is boring otherwise, no? You have to have some challenges in your life. And build on, that's a great one, build on successful elements from other group models. Well, there are many out there, so that shouldn't be too hard. So, why implement it in Leeds? It does make a difference, believe me. I've been around now for some time, almost retired. I've been around for some time. This is the only thing in my long career that I saw really made a difference. Outcomes are likely to be better also postpartum. It will provide your clients with a support network, and I think that is essential. We should stop being knights on the white horse and save people. We have to help them to do that together. But most for all, especially in the UK, where staff resources are bad, and I know healthcare systems here, it's even worse than, well, it's not so bad in the Netherlands, but it's worse than in the Netherlands. It's fun. It will revitalize you, because there's a lot of laughter going out there in these groups. So if you don't do it for your parents, do it for yourself. That's it.